disclaimer is finished. And we are live. Go ahead, Dr. Merlin.
All right, welcome everybody to another episode of EMS Journal Club. If you notice, we are starting and it's not even 1:05 yet. Hopefully, please share this on your Facebook, Facebook like, and so we can get everybody. Hopefully, we'll get about 1,000 to 1,200 of you live with us, and then 7,000 viewers, which are the numbers we're getting. Pretty impressive. So we start today interview season. If you haven't forgotten, we are the biggest ACGME accredited EMS Fellowship in the United States with 6 spots. And more importantly, you have hopefully signed up already for our EMS conference. We already have 300 of you signed up, but you need to go today to sign up so you can reserve your spot. We will have New York continuing education credits, New Jersey CEUs. The following year we'll work on CMEs for docs and nurses, but this year just for providers. And we're going to have award ceremonies. Every dollar we collect, we're going to spend toward putting somebody needy through paramedic school and with financial need. So please come, go to our website, www.emsfellowship.com, to sign up for the conference. Get your seat now, and it's going to be an exciting evening. Make sure you get there on time. Parking will be, I'm sure, not easy. There's one garage across the street, and if you bring an emergency vehicle, we'll have you park for free. Any questions, please type them in and let us know, and we're going to get started. Today we should be done in like an hour and a half. Let's go to the beginning. Interesting cases, anybody?
I have one. This was actually when I was working in the ER, but heavily involved EMS. So basically we got notified that there was a cardiac arrest coming. That's really all we knew at the time. EMS rolled in, and they brought in a 60-year-old male. He had previously had some unknown arrhythmia, which we later found out was AFib, had an ablation that was about a month ago, stopped all of his cardiac meds and blood thinners.
So I'd like to try and guess before you go on, like a little bit of information, and I guess everything, right?
Yeah.
It's what we do when you read the CPC New England Journal of Medicine, right? So he's 60 years old, arrhythmia, I could have guessed AFib, right? Because hypertensive cardiovascular disease making his left atrium bigger and subsequently going into AFib or A-flutter, right? The most common arrhythmia, and probably intermittent, transient.
And we had to guess because the family said he had some electrical problem with his heart, and then he had some procedure, and that's literally all they knew. They had no records at the hospital we were at. So it was all done at an outside hospital nearby, but that's all we knew. His cardiac arrest, some prior arrhythmia a month ago, some prior procedure with the cardiologist, and went home and they stopped his medications.
But AFib usually doesn't cause people going to cardiac arrest, right?
Right.
And it's usually
so that initially I was thinking this is maybe an accessory pathway or SVTs or something else. Later we settled in on the AFib.
But you almost never get new onset SVT at 60 years old,
right?
So that's uncommon.
Right. So he was brought in by EMS. The report was he yelled out his wife's name. She went in the kitchen to see what was going on, and she found him on the floor. So essentially a witness arrest. I'm not sure if it was police or BLS, but someone got there relatively quickly, approximately 10-minute mark, 8-minute mark, and put an AED on. The initial AED shocked him. He had 4 or 5 AED shocks by BLS. When ALS arrived, they started CPR with incidentally a Lucas device. ALS arrived. His initial presenting rhythm was VFib. They shocked him again and did epi ×2. And then intubated him, and then transported him because they were relatively close to the hospital. En route, they also he was still in VFib and still had a VFib rhythm, and they did 1 dual sequence shock in the ambulance with no effect.
So far I understand. So he yelled out his wife's name, and then he went to cardiac arrest.
Right.
And no comment there. So some were smart enough to do a double sequence defibrillation, which, despite some conflicting literature, we wrote the second paper after North Carolina, we're supporters of it, right? Because we believe it works. And despite the fact that a few people are doing the wrong thing, which is they stopped doing it because they were worried they wouldn't honor their manufacturer agreement, I'm more interested in saving people's lives than that. And I understand that nobody has rejected the manufacturer agreement based upon not doing a double sequence defibrillation.
Right.
And so the one converted the patient?
So it did not convert, and they did that double sequence basically in the parking lot, and then they brought him in to me. And so you now know everything I knew when I first saw this person. When I first just looked at him as they're moving him over, he actually looked relatively good for cardiac arrest. You know, sometimes we see these people way down the pathway of cardiac arrest, and you can tell that they've already died, right? They've fixed and dilated pupils, they look totally cyanotic, or maybe they have other signs of death, and this was, you know, just too far down the pathway. But he actually had relatively reactive pupils with the Lucas device going, and then so we decided to look at the rhythm. I actually had already set up the ultrasound. I looked at the ultrasound and felt the pulse because it was unfortunately just me and a nurse and the EMS crew that were there doing the initial assessment. He had no pulse. As I looked at him and looked at the monitor, I set the ultrasound next to the monitor. I saw the fibrillating heart on ultrasound and saw it on the actual EKG machine as well, so we knew we were going to shock him. But I noticed when they first put him over that it looked like his pads were out of place. So he had one high up on his right shoulder, and the other one was really almost on his hip. It was really, really low, I thought.
So did they didn't have 4 pads on?
So they did. They also had the anterior posterior pads from the crew. But the one that we were going to use was the traditional pad placement because the other connector was not compatible with our device in the hospital there. So I thought it was really low pad placement, and we've been unsuccessful so far. So while they were getting IV access, I actually moved up that pad. That was when we had done the pulse check while they were getting the IV access, second IV access, and then we decided to shock him. I shocked him at 360 because we'd already had multiple there, and on my first shock, we got conversion. So,
so I don't know what to say. I mean, this is, this is like a Paul Pepe belief that it's not the amount of joules that you're shocking people with double sequence fibrillation. It's the extra vector that you're creating, which I think we believe as well. And you were just creating a different vector at that point. So you were creating a different vector, and you converted them right away.
Right. After multiple, 7 shocks, I believe it was, including one double sequence.
And you didn't go to a double sequence, right?
So that was our next step, but we didn't, because of our limited hands, we had to pause the Lucas device and put out pads. So they already had them in hand, we just hadn't yet done it.
So you actually went to a lower amount of joules.
Right.
So you went to a lower amount of joules, and you didn't actually add a vector, you just changed the vector.
I just changed it because I think it was too low. I actually think it was below the heart.
We really freaking have no idea what we're doing.
Yeah, so maybe the double sequence isn't really, I mean, maybe it's just the single vector that's causing the change. So we do it at the same time, and I mean, it may not be related to the amount of joules that we're giving. It just, so I mean, what if you did a study of the double sequence versus just changing the pads? Or you can have the 2 pads on, just using one machine to shock, or just switching one pad.
So what about just doing it? What about tonight when you go work somewhere, when you have somebody in a single defibrillation, does it work just changing the vector like right away?
I think that's very reasonable.
I do that. This is not the first time I've seen that, and that's what made me so suspicious. This guy, best we know, had no major medical problems and had a quick response, had good CPR through this, and excellent job by the BLS crew who did truly good CPR, and even bringing him in, good CPR. And
some naysayer out there is going to write in and say, well, maybe it's the fact that he had just gotten some antiarrhythmic and that was just kicking in.
So it could be. Right. So very shortly, almost, I don't think it was before, I think it was right after, but it was hard because we were doing so many things at the exact moment. But I did also add lidocaine. He had already gotten amiodarone in the field 20 minutes before.
Right.
And
so the only really antiarrhythmic that's ever been shown to have outcomes benefit is lidocaine in children, right? That we reviewed that paper, not amiodarone.
Did they ever do a study with like using antiarrhythmic right up front with the shocking? Like, let's say at time 0 you give lidocaine and shock at the same time.
Yeah, but
we wait so long.
There's no outcomes benefit except in children.
Right, but I'm asking, when was the time that, like, I don't know the study, so like, when was the time that they gave the lidocaine, for example? Because if you give the lidocaine 10 minutes into cardiac arrest, maybe it doesn't make a difference, but if you give it right up front.
But who knows what absorption rates are on bioavailability in people in cardiac arrest? I mean, even if I knew the answer to that, I wouldn't know how it makes a difference. Then I would say it's based upon your ejection fraction. I mean, it took them so many years to find all these centers to find kids in VFib arrest, and they were mostly cardiac kids, but all different cardiac disorders too. That's why it was so amazing to me that lidocaine showed an outcomes benefit.
Drew, do you know what the end title was?
So the initial end title was 26, I believe. It was good. The initial end title with CPR, with VFib was good.
The webinar that I sent out to you guys the other day, they talked about when they had an end title under 20, they didn't have any conversions. Mm-hmm. But when it was above 20, they had a conversion rate of like 86%.
Yeah.
We did a study similar to that. We talked about a study similar
Right,
to
we
that.
talked about a study similar to that a couple of weeks ago. You know, but I mean, to me, that's an observation. It's an observational study. So that's saying sicker people do better, or sicker people do worse, and healthier people do better. In fact, they found an observation to an end-tidal CO2 greater than 20 having better outcome. Yeah, I bet if they had studied it, you know, I bet 20 showed even better and 25 showed even better. I mean, it's interesting. It just basically says if your left ventricle is working better and your end tidal is going up, you have a better chance of survival. All right. Yeah. I mean, I probably could have guessed that, but it's important to study.
But I definitely think it's something to think about, and you know, because if you're just doing the same thing over and over and over again and it's not working, are you going to continue to do the same thing over and over and over again?
Right.
So I think it's just another way to think about, all right, maybe if you don't have two defibrillators, or maybe you don't even need the second defibrillator, but maybe it's just putting on two different pads and switching one to the other, or just taking off the pads that are there and moving them quickly.
The other
What
thing
did the
is,
EKG show afterwards?
The EKG was basically silence with him after the fact. There was no STEMI. He had early on, he had multiple PVCs, almost like a bigeminy, but quickly came out of that.
So, of course, the next question is based upon the literature we've reviewed this year. Did that patient who did not have a STEMI go to the cath lab?
So I did advocate for getting this patient to the cath lab. He had some unknown cardiac disease. I didn't know. Maybe the procedure was a cath. Maybe it was a stent. I didn't know.
Right.
I did call a cardiologist. They elected not to take him to the cath lab. His inotrope was something small, consistent with cardiac arrest.
Right.
And it ultimately, we found out that it was AFib after a long, complex.
Because we know
history
30% of
research.
people have a culprit lesion who don't have a
Right.
STEMI on EKG.
Right. But at the end of the day, that's what it probably was. It probably wasn't the MI that caused this arrest. It had nothing, presumably, to do with this prior AFib.
So he went to the cath lab the next day, probably.
He should have. That was the plan. I don't know if they ever.
But even if the next trope is higher, I don't know what to make of it. You know, like he needs to go at some point, right? So I don't know. Maybe that's what we do from now on. What about you guys? Single defibrillation doesn't work. Somebody goes in front of you. What about just changing where the pads are located? I guess you're trying to get more of the PMI or more of the left ventricular mass.
I've done it before, where you look at the heart, you see that it's displaced to the left. You know, you try to. I mean, I try to visualize the vector. You know, I'll see where's this path, where's this arc of electricity going. I mean, if the path's all the way down here and the thing's up here and their heart's displaced to the left, it might not be appropriately, you know, placed. I mean, I don't know.
Right, but of course you have an ultrasound machine.
Yeah.
You keep an ultrasound machine with you 24 hours a day, 7 days a week.
Yeah.
So
By my bedside.
But what would you do with EMS? I mean, what would you tell them to do? Would you have them change the pad placement?
You mean EMS doesn't have ultrasound? I mean,
We're working on it, you know. We're working on it.
well, it's definitely more accessible. More people have extra pads, not extra monitors or ultrasound machines. So to change,
Yeah.
Bob, remind me how much a pads cost?
Pants are only about $25, $30 or something
Yeah.
like that.
So
I think that the idea about putting, if you didn't have two defibrillators, about putting multiple pads on and then using different pads and the different vectors, you
just
know,
kind of
would
switching.
make a lot of sense.
Yeah.
So you
Yeah.
would put 4 pads on from the beginning and then just switch what you plug in?
Yeah, I think that, you know,
And that's better than
if you
just-
didn't have the availability of two monitors, that would make sense.
that's doable.
But it'd be much less expensive if I still only use one set of pads and had the crews move the pads, right?
If you had one monitor and multiple pad placements, yeah, I think that makes sense.
Because we have a couple of cardiac arrests a day, right?
Adds up
Makes a lot of
quickly.
sense.
Yeah.
So
I think it's not a bad idea.
Well, that
I would
happens-
say go in, you know, get your pads on, however they, you know, put them on as the proper way. Start doing CPR, give a shock, and then if it doesn't work, you know, maybe the shock doesn't work initially because they're not kind of resuscitated enough with the CPR. So maybe do 1 or 2 shocks, and then after that, if it's not working, I would do something else at that point.
So Mike, you're doing ultrasound and then you're looking to see where the most of the left.
I do that frequently with cardiac arrest. I you know, do an ultrasound, try to get a subxiphoid while they're doing compressions. With that, you can have them switch their compression positioning based on maximizing the left ventricle.
Which is what we do, right?
And yeah, and then if they're still in VFib or they need shocking, I'll, you know, try to optimize the pad placement based on what I think is the best vector. I don't know. There's no science behind it. It's like try to imagine where the most meat of the heart is and try to line up your pads so it's going to cross them.
Gosh, I want to do pre-hospital TE so bad.
Yeah.
I just got to figure out a way to operationalize it, which is very challenging.
Yeah,
The question
that's-
is that, do you think there will be any delay in the application of these second pads and compressions? So that's
Right.
the one thing that you don't want to do is create some type of delay or any inefficiency in the amount of compressions that you're delivering or the effectiveness of your
Well,
compressions.
everything is, I think, to me, is a risk versus benefit, right?
Right.
So I'm thinking that I know that the best thing to do for somebody who's a VF is convert them with the lowest amount of energy. I have no idea what that is for each individual person, but I know it is probably weight-based, right? Although that's not what we do with adults, right?
Sure.
And I know that if I do we do our double sequence after 3 single defibrillations fail. Is it better to try and convert somebody with another single with a move vector versus going to a double sequence, risking more of the myocardium to be hurt? I don't know the answer to that.
I thought
or
the
is
whole-
it delay, right? Are you risking a delay in converting them out of VF?
I thought the whole reason why we switched to biphasic was that it supposedly like measured the resistance between the pads and adjusted the joules based on that and amps.
Yeah, I think we were told a lot of crap. And then Ian Steele published a paper which said that monophasics have the same outcome as biphasics. And I always joke that I have a bunch of, monophasics in my basement that nobody wants anymore. But
They work just as well.
they were just, we've got this bidirectionality of electricity. We were told all these fancy things that never panned out.
Yeah.
But despite that, we all bought,
Fancy new monitors.
Yeah, we bought biphasics.
So the only time you would actually have a delay is if you put on anterior post, the anterior.
Yeah, because you've got to
poster.
roll.
Right.
That's your only delay.
Right.
So maybe the idea would be, your first set would be anterior, posterior.
Sure.
Or if you're putting on 4 pads right from the start.
Yeah, that would be, because you put that on, start your compressions, and then put on your anterior lateral.
Right.
Right. That sounds good. As all responsible EMS folks, we're going to have to justify this to the financial people who will say X number of cardiac arrests per year, 2 extra pads, $25. That's totally fun. You can do this, but you can't do, nasal and tidal CO2 next year.
Maybe we say we'll stop giving epi during cardiac arrest. Save money there.
Yeah.
All right. So what was the
And by the way, I did also have my metoprolol in my hand. That was
Yep.
literally my next step.
Yep.
It was just which thing do I pick first? He's fibrillating. Let's shock him because we already had pads. I didn't put new pads on. I unstuck the pad they had. I just put it higher where I thought it would be better.
So like any good EMS physician, Drew knows that the literature for epi with outcome is terrible in cardiac arrest, but there are 2 papers, one by Joe Renato, which we reviewed, and several dog papers where we're talking about human papers, which show better outcomes when people are giving metoprolol in cardiac arrest for VFib.
And this person already got 2 rounds of epi.
Sorry, Esmolol.
Esmolol.
But you had, but Esmolol.
I didn't have Esmolol available.
Yeah.
But this person already got 2 epi. It didn't help him. It was unlikely to help his refractory VFib. So I asked the nurse to hold it. And of course, they gasped. Someone dropped a glass in the background, but it was the right thing.
Did they wonder why you're asking for metoprolol in cardiac arrest?
They did. I had to go circle back around
And did you say
explain what
because
happened.
I'm years ahead of everybody else?
But they had never seen lidocaine used as well, so that was another. I think that it was just.
Well, that
I
used
was
to
in
be
the
our
right place at
go.
the right
That
time.
used to be our go-to drug.
Right.
It was like a
So,
paper that-
so when I was younger and a nerd, before we had all this social media and all this access to everything, I used to carry all the articles in my bag. So every time I was in the ER, I would take the article out of my bag and say, this is the reason why we're doing this. It must have been very challenging to work with me. It's kind of obnoxious. But it worked, because then you give people an article, and now you have to send it to them. That was
So the outcome, this guy did have sustained ROSC. He's on day something 5-7 of the hospital stay. It looks like, unfortunately, he has presumably an anoxic brain injury, although we did cool him, and we'll see how it plays out. But as far as heart goes, he had no further arrests.
so interesting. You don't know what his echo was, do you?
I don't know.
I always
When was
wonder
that
about these
going
people
down?
who have preserved
This is a very
ejection
long
fraction but
delay.
yet have an anoxic brain injury. Something was doing well to give them preserved EF, yet they still have an anoxic brain injury. How does that happen?
I
Well,
wonder
because
the
if
same
you have
thing.
damage to myocardium causing an anoxic brain injury, you think the EF won't be preserved.
Right.
Maybe with the compression, the heart's just closer to the circulation.
So you have better blood flow through the
I mean,
coronary
Better
arteries.
just-
blood flow through the coronary arteries, so you probably don't need to compress as hard to preserve flow to the coronaries versus the brain.
Right. But our depth of compression is also oftentimes related to our body habits.
The coronary, right, to our own,
Our own, yeah.
Yeah, for sure. So, I mean, we gotta look at who's doing the CPR on this person.
Right.
'Cause, I mean, I get the coronaries come right off the aorta.
Right.
So you probably don't need to compress as hard to get blood flow there.
And we all know that 50% of us don't compress according to HA guidelines, and the best compression depth is 1.7 inches, which we still can't figure out how to do it. Any other interesting cases?
I had one yesterday. I haven't had a chance to follow it up yet, but it was very strange. I had a guy in his 60s called for palpitations. He called EMS for palpitations and felt like his heart was racing. Said, "I feel like I'm running a marathon." We've heard all these things before. So showed up to find him sitting on his couch, no acute distress. Hooked him up to the monitor, and he was tacking away. It looked like AFib, RVR, probably 150s to 160s. Started to get
So
a
we
little
could have
more.
guessed that, right? 60-year-old hypertensive cardiovascular disease makes his atrium bigger.
Mhm.
You know, if his left LA is bigger than 4.5 centimeters, depending on who you believe, it'll be hard to convert him.
Yeah. Now he had recently been discharged from the hospital. As I got more information from him, he had a pacemaker put in 2 or 3 days before,
For the AFib,
presumably for the AFib.
right?
So he still had a fresh scar, everything like that.
So, I mean, just thinking out loud, when you put a pacemaker in people, most everybody gets a DDD pacemaker nowadays, except for AFibbers who get a VVIR, right? Because one way, because you can have refractory AFib, and if it doesn't work, if nothing works to convert somebody, what you can do if they remain tachycardic, just by drugs, you can ablate ablate the AV node and put a pacemaker in, and you've cured their AFib. So that's one strategy in the cath lab. That's why when you go to the lab for AFib, sometimes it says you might need a pacemaker.
Okay. Yeah, and presumably that's what I was thinking. He got it for the AFib. Actually, I think I said it was a few days ago. This was a few weeks ago. And then I think he went back into the hospital for something related to the pacemaker, had it switched. He wasn't really sure, and then he was discharged again. Now he was called, and he had these palpitations, heart rate in the 160s, AFib, RVR, and his blood pressure is probably 90s over 60s. Rest of his vitals were okay. And like I said, no acute distress. Long story short, all of a sudden I started to see what looked like pacer spikes in between the kind of interspersed within the AFib with RVR. It was very strange, but it wasn't capturing. So you could see there was an attempt to kind of pace. There was just no capture. And I talked to him a little bit more. He said, yeah, this has been in for a couple of weeks now. It's just really itching me. So he's been itching this little pacemaker for a while. And I haven't followed it up yet. But what we were thinking was he was itching it enough, and when I felt the pacemaker, it felt like a sublux patella. You know, it was kind of floating around freely.
Like
I think he
Twiddler
had
syndrome or
Twiddler
something?
syndrome. He was playing with it, and I think the pacer leads must have dislodged. That's why they weren't able to capture. But for some reason, they were still able to kind of pace. So I did look at his heart with the ultrasound. He had a very trace pleural effusion, but no tamponade, nothing like that going on. I couldn't really see the pacer leads that well, but I'm going to follow it up and see. I think he had just twiddled it enough that maybe the leads pulled out. Maybe that's why he went into a couple days ago. I just thought it was interesting how the pacer was attempting to pace, even though if the leads were dislodged, presumably. I don't know. Have you guys ever seen Twiddler syndrome before? I feel like I see it every week now.
Every week?
I think we
Not
talked
the
about
same
it
guy,
once, and
is it?
since then, it's everybody who gets a pacemaker has to sit there and play with it. So
What was the
pull
initial reason he was itching? Was there any? Was it like everything?
I think it's just healing. It was just healing, itching. It didn't look infected or anything like that. I pulled back the dressing. It looked fine. So.
How can he get to it if it's all the dressings there? you know?
He was showing me how it was itching. He was taking the pacer and moving it around in that pocket.
So you wind the pocket and disrupt the pacer leads. So do you know what happened, or?
I have to follow it up. I'll let you know next week, but I wasn't able to log on and look because it was just yesterday. But it's interesting.
Pretty interesting. All right. Any other interesting cases? No. All right. Why don't we go to the articles? Do we want to do this? Which one do you want to do first?
Either one. I can talk about the
All right,
dispatcher
why don't we do the dispatch article first?
CPR. Okay, let me put the picture of the article up here. So this was, yeah, I feel like throughout this fellowship, I've developed an interest in dispatch and what we can bring to patients earlier. And this was kind of a great interest to me because this was directly looking at outcomes and really what happens in a situation where pre-hospital cardiac arrest and whether or not dispatch or CPR instructions are actually going to do anything. It's actually been pretty well studied so far, from what I could tell. So this was an article. Well, this was the Wyoming one, right? This is
Wisconsin.
Wisconsin. You're right. Christy Weinmeister et al. Out of Wisconsin, Milwaukee, Wisconsin, and essentially, you know, their introduction, great background. They quoted 12% of individuals who suffer out of hospital cardiac arrest will survive to hospital discharge. I guess that's with the data that they had available to them. What's our number?
It's a pretty, 12% is a pretty big number.
Pretty
Whenever I
high.
see these numbers, I always wonder what's real and not. But many major cities are doing much lower, 2 to 3% in terms of outcome when it's looked at rigorously.
Right.
But if you look at VFib, you get up 10% or higher. You know, it depends what rhythm you're looking at. So you can get higher numbers if you're looking at certain things. If you're looking at ROSC, some people are reporting 50% ROSC, but again, that's what they're reporting, not what's been published, and I don't know if that's real or not.
Right. And the thing to keep in mind is 12% of individuals who survive to hospital discharge, a certain percentage of those are going to LTAC on a ventilator, you know, who may not have the best neurological outcomes. So that's all something to consider. And we know, we're drilling this into all of our providers, EMS, nurses, and lay people that the chain of survival, right? Early CPR is what makes the difference between life and death and outcomes. When CPR is started by bystanders, odds of survival increase by 2 or 3 times in some studies. That's what the AAH talks about, and that's why they're really pushing for their, early chain of survival structure. So that's been great. And there have been some big studies, one out of Seattle. They looked into CPR instructions given via dispatch and how this is related to bystander CPR. They've increased their survival from 26 to 68% in 30. Sorry, not survival. They've increased their rate of bystander CPR from 26% to 68% in a 13-year period. That's insane. Now that we know bystander CPR works, and then their cardiac arrest survival rate went to 22% compared to 12% that the nationwide survival rate that they were comparing it to. Arizona also did a big study. They were able to increase their bystander CPR rates to above 67%. That's great. And Singapore increased from 22 to 42%. So everybody's publishing this, that they're increasing their bystander CPR rate. That's great. So this group, they looked at their own population. Their objective from their study was to determine if there's a difference between EMS documented bystander CPR rates based on the age group of everybody receiving bystander CPR, out of everybody who had cardiac arrest in the field. It was a retrospective chart review, and this was Milwaukee County in Wisconsin. They had 241 square mile area, so that's about a little less than 1 million population, 900,000 about. And they had a medical dispatch system, version 12.2 of the priority dispatch. I don't know what, I've never seen that before, so I don't know what entails with that system, but it's relatively new. They also had a quality review program to make sure there was appropriate follow-up. When a patient collapses, 911 is called. A tiered response, similar to New Jersey. Tiered response, you have a closest unit, which is usually BLS. There can be an ALS unit on board, and then you have a advanced ALS system dispatch as well. So multiple people responding to the scene. And let's see, their study protocol, they essentially retrospectively broke all of their out-of-hospital cardiac arrest down into a few groups. The groups were child, 0 to 12, adult, 13 to 54 years old, and then geriatric, which is greater than 55. Okay, greater than 55 is geriatric now. they went on, basically they also characterized their initial rhythm based on PEA, asystole, VFib or VTAC. So they have not adopted the Littman, PEA. Obviously, we would like to see that as a breakdown.
And that was a few years ago,
That was a
right?
few years ago, right? So every cardiac arrest, as we feel, should be broken down into PEA, wide complex, narrow complex, and kind of go from there. So their results, you can kind of follow along on table 1, but they had about 1,993 cardiac arrests over the study period. Asystole was the initial majority, initial rhythm, and bystander witness arrests occurred in 48% of all cardiac arrests. That means it was witnessed, right? So that's the first big hurdle. Bystander CPR rate they got was 10%. Wow. If you look in table 1, their bystander bystander witness arrests, out of all of those arrests, it was 1,900. There was 967, so that's 48% were witnessed. And what I thought that was interesting, the way they reported it, bystander CPR was 10%. Now that's 205 patients, but that's out of all 1,900 patients. I think that they should have reported bystander CPR rate as a rate out of all of the witnessed, right? So I think out of that group, the 967 patients who had bystander witness arrest, out of those, it's actually closer to 20% who received bystander CPR, which is still not optimal, right? And their ROSC rate was 40%, which I think is comparable to the nationwide average. And then, looking at table 2, they broke it down for even further, comparison by bystander CPR based on age group, and they showed that in the 0 to 12 age group, the kids, they're at a higher rate of bystander CPR. It's up to 17%. Total cases, as they reported, was 10%. So that was interesting. I guess people are more likely, to do CPR on a child than an elderly person.
Maybe it was a family member, relative with a
Family
kid.
member, relative,
Their
right?
N is also very low. And I think they do teach CPR like in not birthing classes, but like early on, like when kids go home, things like that.
Mhm.
So it's still fresh in people's minds.
So, their discussion, they got into kind of what goes into the thought process of doing bystander CPR. The most reported rate or the most reported reason for failing to perform CPR by bystander was bystander panic. They just freak out and they panic. They don't know what to do. And so after this data kind of comes out, a lot of dispatch systems now are directing their dispatchers to coach and focus on the bystander's emotional response first, deal with that, and then once they're proven that they're capable and maybe they've calmed down a bit, say, okay, this is what we're going to do. Your ambulance is on the way, but this is what you have to do. Kind of focus more on the bystander instead of saying, okay, get your patient on hard surface and start compressions now.
Or you have 5 to 10 seconds to feel a pulse.
Yeah.
If it takes you 20 seconds, it's okay, right?
Right.
If you do 35 to 2,
Mhm.
it's okay.
Just do something. Just don't do it.
Right. And unfortunately, a lot of the times when we show up to a scene, you see, okay, it was a witnessed arrest, but the family is kind of sitting there on the couch crying, and, well, maybe you should have started compressions. That would have really, but it's certainly the panic is there, the panic effect. They say family members did make up the largest proportion of bystanders who performed CPR. So 65% of everybody who received out of bystander CPR, 65% were family members. Let's see. Another studied barrier to performing bystander CPR was the physical status of the bystander and the body habitus of the patient. That's one thing that was reported as a routine barrier. People, I guess, it's a morbidly obese patient. They feel their compressions won't be effective, or I'm not in shape. I can't maintain this. I can't do compressions myself. I guess that's a reason as well.
Did they ask like what the dispatcher said to the caller, did they say, or do you feel like you're capable of doing CPR versus?
No, they did
Here's
not.
what I need you to do.
So the existing protocol that they used through this program was to instruct, if the dispatcher felt that this could be a cardiac arrest, immediately go into the protocol, which instructed them to move the patient to a hard surface. That's the first barrier. If they couldn't move them to a hard surface, they would basically abort the protocol, from what I was reading, because they felt compressions would be inadequate on I don't know, in the water, on somebody's bed. I think it's probably better than nothing. But if you think about doing compressions on a bed without a backboard or a hard surface, it's kind of hard because the whole bed's bouncing up and down, right?
So you gotta get an extra firm mattress.
Yeah, extra firm mattress. It
Just
really.
in case.
Minimize the time to compressions.
So what else with this? So, I mean, they had several limitations, obviously, as retrospective. It relied entirely on paramedic chart documentation. Most of the Nemesis data now requires you to report an all-cardiac arrest, whether it was witnessed or not witnessed, whether or not CPR was done. I think those are required entities, as we learned at the Department of Health last week. But they were able to find, overall, the rate of EMS documented bystander CPR was low, even if these municipalities provided dispatcher-assisted CPR. So even with the dispatchers coaching you, telling you exactly what to do, bystander CPR is still painfully low, unfortunately. And then they showed, as we said, higher rates of bystander CPR in kids. That was statistically significantly higher at 17%.
I thought that the witness arrests were high. Like, I think that's some of the biggest problems with our research into cardiac arrest is we need to separate witness and unwitnessed arrests because they're two different populations. Because unwitnessed arrest could be 30 seconds or it could be 30 minutes, and your outcomes would be very different. But your witness arrest is just better to work with that kind of data.
Right.
I think it would be interesting. I guess when people are in the heat of a moment of seeing someone in cardiac arrest, there inherently is going to be panic there. And as physicians that are trained in emergency medicine and EMS, or as paramedics that are trained in EMS, like this is the stuff that we're dealing with, and the EMTs as well. This is the stuff that we're dealing with every day. So when we see it for the first time, there's no panic involved. So.
Well, that's the thing. It's not the first time for us.
Right. So that's
like,
the thing.
Do you guys remember your first cardiac arrest? Like, I don't even know if I remember it. I think there was just a lot of adrenaline. Right.
So for the average person who doesn't see a cardiac arrest ever in their life, and now they're all of a sudden seeing one, to ask them to go do.
And it's possibly a family member too, which
right.
Makes it even more.
And maybe they've taken a CPR class 10 years ago, or maybe they've never taken a CPR class, or they're scared of the CPR class that they took because there was so much information given to them and they just can't remember anything. Maybe doing dispatch CPR in combination with widespread training of just very simply how to press on someone's chest would increase the amount of bystander CPR that would get done, because there would be an inherent some comfort in having done it before without all this like confusion of the numbers and how to do it and all this kind of stuff.
And I think most systems now, even to increase their numbers of bystander CPR, it's the unresponsive patient. They just have them start pushing on the chest, whether or not even check for a pulse.
We talk about CCCPR all the time,
right?
And there is, I think, 4 studies where there's a clear benefit, not in children, but in adults. AJ, not much in stats here, right?
Yeah, not much. I'm in agreement that the Table 2 is ambiguous and it should be bystander CPR rate out of those who witnessed. That's pretty much my only comment, unless you have a question about chi-square.
No, but you want to remind us what it is?
Yeah, chi-square is frequency counting. It's categorical frequency counting, and just compares the differences in frequencies among your categories.
Right, okay. All right, sounds good. You want to move to the next article, guys? Which one do you want to do next?
I can do TNK.
Okay, let's do
versus TPA.
TNK versus TPA. This was in last week's New England Journal of Medicine.
Yeah.
Okay.
So,
Can you just increase his input a little bit?
so this is tenecteplase versus alteplase before thrombectomy for ischemic stroke. So this is in New England Journal of Medicine, and what the study was, it was looking at patients who had ischemic stroke of the internal carotid, basilar, or MCA in patients who were eligible to undergo thrombectomy. So what they did was they either gave them tenecteplase or alteplase, and they tested for the non-inferiority of tenecteplase, and then afterwards tested for the superiority of it. So this was only in patients who were planning to get a mechanical thrombectomy after getting the either the TPA or the TNK. So this study really didn't look at the outcome of patients who would just get TPA or TNK on its own. So there were 202 patients that were enrolled. 101 were assigned to receive tenecteplase, 101 to receive alteplase. Alteplase it has to be given over an hour versus tenecteplase, which can be given in a bolus because of its longer half-life. So there is some different factors in the medication administration, which I think are important to understand when also deciding to give a medication. So patients were eligible if they would undergo IV thrombolysis with either the TPA or the TNK within 4.5 hours of the onset of the stroke, and they had cerebral vascular occlusion on CTA of the internal artery, of the internal carotid, first segment of MCA, second segment of MCA, or the basilar, and if they thought they would be able to get the treatment, the intraarterial clot retrieval basically within 6 hours after the stroke onset. So this was definitely limited in terms of the patients that who had a stroke that were kind of enrolled into the study. So they were assigned a 1-to-1 random ratio to receive each. And the primary outcome that they looked at was substantial reperfusion, which was defined as a restoration of blood flow to greater than 50% of the involved territory, or an absence of retrievable thrombus in the target vessel at the time of initial angiographic assessment. So it looked at basically at the blood flow, and then it didn't really show, their primary objective wasn't to look at the outcomes basically of the patient. So, maybe the blood flow got better, but if they can't move their arms still, that's something to kind of keep in mind as well. However, if they were not able to do angiography, the primary outcome was assessed as reperfusion of at least 50% of the involved territory on CT perfusion images 1 to 2 hours after thrombolysis. So then the secondary outcomes were the modified Rankin scale score at 90 days, and then improvement defined a reduction of at least 8 points or a score of 0 to 1 on that NIHSS scale at 72 hours. So what they found was that the 101 patients kind of in each arm were enrolled in the study. 2 people were excluded due to withdrawal of consent. So they found that reperfusion of greater than 50% of the involved territory occurred in 22 patients who received tenecteplase. So it's 22% these other patients, compared with 10% of the patients, which is 10, who received alteplase. So, and then of the patients that had reperfusion at the initial angiographic assessment, 20 of the 22 patients in the tenecteplase group and 6 of the 10 alteplase group had initial occlusions in the MCA. So the patients in the tenecteplase group had a median score of 2, which was significantly better than the median score of 3 among the patients in the alteplase group on the modified Rankin scale. However, there was no significant differences in the incidence of early neurologic improvement at 72 hours, which I think kind of goes with the other studies that we've looked at in terms of giving thrombolysis during stroke, that we're not really seeing much difference in the outcomes right away.
Such as the
when we do
NINDS
this.
trial, where nobody got
Exactly.
better right away, and every time people say, I had a patient, I gave him the drug and they got better, it's because it was a TIA,
Right.
not because they were getting better because of the drug. But it's interesting, they used 3 months and on a modified Rankin scale instead of NINDS.
Right. So, in terms of complications, they had intracranial hemorrhage. It occurred in 2 patients, 1 in each group. And I think there were 10 deaths in the tenecteplase group, 18 in the alteplase group.
Which is low numbers, by the way,
Right.
right? I mean, if I remember at the end of this trial, the rate of intracranial bleeding was 6.1%. So this was, I mean, it's hard to
This is
make.
like 1%, basically.
Yeah, I mean, it's
of
one
the-
patient, so it's
right.
still a small sample
Right,
size.
right.
Although NIDS I think, had 250 patients or so.
Yeah. So, overall, so in the TNK group versus the TPA group, they had, in like the ordinal analysis, they had a better functional outcome, but not according, but that wasn't, but not according to the proportion of patients who basically left with minimal or no deficits, the proportion of patients with early clinical improvement for their stroke deficit. I mean, I guess, it seems like based on this study, which is kind of a small study, it's still only 100 patients that were enrolled in each arm. But it seems like if you're going to go for, at least based on this, if you have a stroke and then you're going to end up going for a clot retrieval, the TNK seems to have a little bit better reperfusion and blood flow to the brain versus the alteplase. So I think for me it's something to keep in mind. I mean, in terms of what I would give if someone wasn't going to go for clot retrieval, I don't think I can really comment on that based on this article. Definitely seems to be more studies we need to get done. I mean, there's always that argument if TPA really works or if it doesn't work, and maybe looking at TNK maybe can provide us a different means.
It is
to
a
do
small
this.
sample size, but I mean, they're the first to do this.
Yeah.
Right? I mean, and I'm not sure why when I think about it. TNK's been around a long time.
Yeah.
TPA's been around a long time. I mean, why has nobody else been able to do this? I'm not sure. I mean, TNK is easier to give, right?
Yeah, it's a bolus versus over an hour.
Yeah, and it's like 0.25 mg per kg, so you just give it once and you're done, right? Right? I think that's right.
Yeah.
And so it'd be easier to give pre-hospitally. I mean, that's why
Yeah.
ultimately, because people are pushing TPA pre-hospitally. It would seem that if TNK was a similar drug or better, then everybody should be pushing TNK
Right,
pre-hospitally
and-
now.
And also for transfers. So if you have a stroke, who's going to go for
Right.
as large vessel occlusion is going to go for angio, it's a lot easier to just give that bolus of TNK
Right.
and then ship the patient off versus having to send them with a drip of TPA in the ambulance. as
Everybody
well.
talks about drip and ship, right? So drip and ship patients. I have to wonder, it's the same thing we always have the discussions about MIs when patients wind up in non-PCI centers, like they do, not around where we are, but all over the rest of the world, they do all the time. And you're going to give TPA before you ship them to a PCI center, which may be 3 hours away. Should we all be given TNK for STEMIs?
I think it's a good question. How did TPA become so involved? Like, why was TNK just left out of this?
TPA.
Because the
came-
pharma companies did a great job, with all of their.
TPA was the Gusto 1 trial. A few years ago. It was this guy, Eric Topol, Topol, who I believe at that time was head of cardiology at Duke. And he was the first author on the Gusto 1 trial, which was the first study which taught us that TPA showed a clear 1% mortality difference versus nothing for STEMIs. And TNK wasn't even part of it. But TNK, if I remember right, TNK came out several years after TPA. But it was a drug that was heralded because it was easier to give. And I would assume it was a similar cost. I don't know. So, I mean, you're going to put a fibrinolytic on your EMS system tomorrow? Is it going to be TNK?
I would look over more into it to make sure. I think it's just as safe, but I think if I had to pick one or the other with this and the way it's administered, it's a lot easier to do TNK pre-hospitally.
I think it's also based on like your response area, you know, having 30 minutes or 15 minutes to a hospital versus like 3 hours to 4 hours is a big difference.
Yeah.
And that would definitely change my,
So you put on your maybe your mobile stroke unit,
yeah.
or maybe you know an area where EMS is right takes an hour to get somebody to a hospital, or maybe there's some cutoff. Maybe it's 45 minutes if it's assigned your geographic area. What's your cutoff?
To give one versus the other, you're saying?
Yeah,
But if it's doing a better job on patients of restoring blood flow, why?
I would do the same thing.
That's what I would do too.
But I mean, if you're in a system where you're 10 minutes from a hospital, I don't know that I would do
Then
it.
maybe I wouldn't carry.
But also, what's the hospital? Is the hospital even a stroke center or a comprehensive stroke center, or,
Right.
you know?
I mean, you're certainly with these patients, you certainly need a CT. So only talking about patients who can get a CT head, and you know, and as we always say, CT angio with a CT head. Or if you're over 6 hours, CT perfusion with a CT head and CT angio. Any other thoughts?
I think we're going to move to everyone to just like stenting of the heart. I think we're probably going to move in that direction towards stroke.
Right. Yeah, I
It
guess,
seems to
but
make a lot more sense.
we don't have enough guys who can stent for a living, right? We
Right.
don't have people who are, I mean,
And the people who are, they're not gonna be on call 24/7.
Right. But I think so too. I just think that
We're not
you
there
just
yet.
need a lot more people go become interventional cardiologists. Really it is. And there are a lot more programs, there's, you know, et cetera, et cetera. All right.
Just as an interesting tidbit, I just came across this Medscape article from June of 2000 that talks about Genentech's brand new thrombolytic TNK is going to be priced at the same price as TPA. So basically, apparently they're from the same company, or at least were 18 years ago. Also, it's just amazing.
Oh, right, so that Genentech company makes TPA,
Yeah.
but so TNK is made by
TNK is made by
Genentech too.
Genentech. Yep,
And it's the same price.
same price, $2,200.
Well, then it's simple. Then, I mean, does anybody disagree we should be using TNK on all the mobile stroke units? I mean, this study took what, 30 years to come out? Although all the
To get 200
the easy
patients?
cop outs always just say we need more studies. Okay, so what are you saying? Let's wait another 30 years. You have a drug which you know is not any high risk of bleeding, which probably does cause more reperfusion. Maybe the next study will show it doesn't. But yet with this evidence, don't
I think
just
for now
put-
I would switch. I don't think there's a downside, and there's definitely a possible benefit, so why not?
I wonder why Genentech came out with a similar product that costs the same amount. Is it because it's easier to give? There must be some reason they did that. All right. Okay, what's next? Oh, sorry, AJ?
Here, let me pull him up here.
Hey,
Okay.
can you hear me?
Yeah.
Yep.
Alright, my only comments on this are basically just the data in general. It does have a low sample size, and something you'll notice on page 7 is in figure 2, there are a dramatic amount of outliers positively skewing our data set, which is why they're reporting median values over mean values. And it can distort our effect size in this study because of the sample size. So
say that again to me, AJ, because I've always been a little confused why some articles report means and other report medians. So what are you saying?
okay, so in a normal distribution, when you have enough values, your mean, median, and mode will all equal the same value. Whereas when you have small data sets, the median will be a better approximation than the mean. The mean will actually be way lower in a skewed data set, and it doesn't estimate your average at all. Whereas the median is not influenced by outliers, so you report that instead because your sample size is not normally distributed.
Right, so does that make sense to everybody?
Okay.
So, I mean, from a clinical standpoint, I would say this is just a tough group to get a higher sample size on ever.
Yeah. So it's probably the best clinical significance that you can find with the effect size. And although they could have done some likelihood ratios to help trim down the outliers, but I don't see that done anywhere.
So when do you determine when it's appropriate to use a likelihood ratio?
Let's see, when you have significance among the differences between groups, you need to then find which ones are are your extreme values, which they seem to have quite a few. Among the eyeball, like 15 extreme values in figure 2. So that's when.
And so how do you eyeball those confidence intervals and tell me if they're too wide?
Let's see. Are you talking about figure 2? The box plots?
Yeah, figure 2.
I mean, they're going to be wide just because of the sample size and the outliers. And you'll see on the middle one at 24 hours, the upper bound gets pulled drastically by the outliers, which is why if you eliminate the outliers, the confidence interval would shrink dramatically.
Right. Well, right. But there's no way to. I mean, there'd be no way to eliminate those outliers, right?
You could eliminate them with 5% extreme outlier deletion. You just need to find the probability that 95% of your values should have fallen in to the data set and those didn't, so you could delete them and report it, and then report that as a limitation to find a better approximate effect size.
Oh, I see. All right. Any other questions? No? Okay.
This is great having a statistician, kind of tell us exactly what this means.
The next article.
So I can do the oxygen titration after resuscitation from out-of-hospital cardiac arrest.
Oh, yeah, I like that.
It's a multi-center randomized control pilot study out of Australia. And this is coming out in resuscitation. We got it a little bit early, so it'll be out soon. In resuscitation near you. This basically is looking at at titrating oxygen after ROSC in people who have out-of-hospital cardiac arrest, and essentially all comers, using a basically multi-center trial. It looks like most of the Australian ambulance services and hospitals are involved, and they have several different kind of stages through this trial. So this one basically looked at the data from all cardiac arrests that had some good prognostic factors. They had to be witness arrest. They had to be, they had to be unconscious adults. They had to have sustained ROSC through the whole course, as far as from the end of the resuscitation. They had to have an initial shockable rhythm. They had to have an advanced airway, but advanced airway included supraglottic airways like LMAs or King tubes or others. And they had to have initially a SpO2 of 95%. So those are their inclusion criteria. They looked at including people over September of 2015 to March 2016, and then they basically were randomized 1-to-1 to either get 2 liters of oxygen after their ROSC, or to get more than 10 liters of oxygen through a BVM, or a bag valve reservoir, which I presume is a non-rebreather. They basically enrolled about 100 people through these two periods of people that had sustained ROSC after witness cardiac arrest, after a cardiac arrest, and then they part of the way through their study, about halfway through into 2016, they actually had to modify their study because they were getting a lot of people that had desaturations to 90% or less on the 2 liters, so they decided to modify the study to make it more titratable, where they could be 2 or 4 liters of oxygen, or the same standard, more than 10 via an rebreather or BVM. They got about 61 patients to the titrated arm, and a similar number on the other. And basically what they found is that they did have some people that had some desaturations, but the majority of the desaturations did occur, of 81% of the desaturations occurred in this 2 liter per minute group. And on arrival to hospital, the majority of the patients had greater than 94%. So titrated people had 90% of their patients. Control, which was the high flow oxygen, had 100%. And all patients had more than 90%. So all patients in the study. So basically, by looking at those 2 data sets, even though they did have some desaturations, the desaturations were never below 90%. And even when they had desaturations, if you titrated it from 2 to 4, then they eliminated that factor. So and the reason that they're looking at this is just like we reviewed, I believe it was last week, having a lot of extra oxygen can be harmful. The more and more evidence we get, the more and more we see that unnecessary extra oxygen and all those unnecessary free radicals are probably harmful and probably harmful in the most important place, in the brain, where it's easy for them to get in, and those free radicals have the most damage. So we saw that in studies for MI. We saw that most recently for basically all comers. People, every person coming into the ER, they were randomized, or people that were admitted to the hospital randomized to get oxygen, non-oxygen, and the people who had no oxygen did better overall, as long as they didn't have, of course, a respiratory or hypoxic complaint. That looks like what they're trying to do at the same study. So these people had cardiac arrest. Presumably, that after this cardiac arrest, right, they've had all their tissues have been hypoxic. So theoretically, oxygen makes sense, right? Their tissue had no oxygen. Now they have ROS. We should give them extra oxygen, but it's looking more and more like that may not be the right thing, and that may not be the case. And it's certainly not necessary from a metabolic standpoint, which is why these people, even on 2 liters, all of them were more than 90%, and most of them, 90%, were greater than a saturation of 94%. So they don't really need much extra, and giving it too much extra certainly is looking more and more likely to be harmful. And then they actually have a phase 2 or 3 of this trial, I think it's phase 3 actually, where they're going to have a lot more enrollment to really kind of hammer out, is this harmful? Right now they're just, the aim of this study was to make sure that titrating oxygen wasn't creating harm. It doesn't seem to be, so now they're going to expand it into a phase 3 randomized controlled trial, which is already in progress, with a goal to enroll 1,460 patients to see if we can kind of conclusively understand this.
So how do we stop giving oxygen to patients?
How do we
teach
stop?
that?
I know how we stopped teaching it in EMT school, because I remember when I was in EMT school, I got taught the same thing. No matter what is going on, the first step you do is you put an oxygen mask on.
High flow.
High flow,
Yeah.
non-rebreather, and if they pull it off and they're trying to tell you what's wrong with them, just push it back on their face and keep them
Well,
quiet.
the first step is changing the textbook then, because that's
Right.
that's the
Right.
base.
That
It's
is-
6, 10 to 20 years.
But we keep
It wants
saying-
to say IVO2 monitor, like,
Right.
why would
Right.
it be oxygen? I mean,
But we
it's-
keep-
it's
right.
pervasive.
But we keep saying the textbooks are 3 to 10 years behind the current way of thinking. It's you're right. It's I don't know how we change the culture. Every time somebody has chest pain,
And it happens in the hospital too. It's my biggest pet peeve to walk into a room. These people have they broke their arm and they're on oxygen, and I'm like, why are they on oxygen?
Feels
I don't know,
Feels
just cause.
Well,
Like,
we
and
still
there's
catch
no
flag.
reason.
We still catch flag for holding off oxygen when we take patients into the hospital. Like it's still
Right.
that hasn't pervaded to any of the hospitals.
Right.
I love
It's
thinking
taught in
people
nursing
having-
school as well. And
he's
that's
having
part of
chest
it.
pain. Why doesn't he need oxygen? People look at me like, you know, go to the CCU, or people are having STEMIs. Are they all on oxygen? You put on 2 liters because it looks good, right? Otherwise, there's no reason, right? He's got 1,000 cheeseburgers there. The oxygen doesn't help, right? It doesn't push the cheeseburgers out of the way in his coronary artery.
Turn up high enough in my.
I think it's just that need to feel like you're doing something to help the patient, and it's always like you put on the nasal cannula and you say, "Do you feel better now that oxygen's on?" And they're like, yeah, I feel so
Sure.
much better. My chest pain's already gone. It's
I mean, I'm guilty. I'm guilty too.
But do we have to turn it
Put it on and don't turn on the oxygen.
Cannula
right?
on and-
right. That would actually be a good study.
And that
So
is actually
placebo.
what I do all the time, because I found if I take it off, nursing or somebody or a tech will come and put it back on.
Yeah.
If I leave it there and turn it off on the wall, or even better, hook something else to the wall and just leave it hanging behind the bed,
Yeah.
you know, then I'm golden.
We used to, and some places still do, all put oxygen on sicklers, right? And there's lots of stuff published on this. That you actually increase red cell destruction by putting oxygen on people who are having acute sickle cell crisis. So for me personally, when somebody has sickle cell crisis, I never put them on oxygen. Plus, I want to see what their real status is under there.
I think the only reason for oxygen in that is sometimes the pain medications are so high that they become hypoxic just because they're,
Right,
completely zonked.
I don't know. How do we do this? I mean, I think we're getting more focused too. Like, if we intubate people, we're starting to like. I mean, for me, I no longer go to FiO2 of 100% on the vent after I intubate. Right?
Yeah.
I start like at 60ish and that's only because I used to do 100. So 60 is my trend downward, and I'll go
I
even
just
lower
do
eventually.
40, if not 21.
Right.
Yeah, I stand at the bedside and just turn down the.
If I need to go
oxygen
up, I'll go
and just
up.
watch the pulse ox.
What if we post
No.
a sign on the door of the hospital that says effective immediately, no patients be brought into the ER on oxygen?
Unless they, well, I think the other problem is.
Well, I did that with backboards. And everybody was like taking pictures of the sign and then sending it to these people. And, and then they were sending it all over. And I'm like, and by the way, nobody ever contacted me directly as a result of that. Nobody ever sent me an email and said that you can't do this. But they were sending it to each other. Right? It never made any sense. And now, of course, all the people who send the pictures, now they're not using longboards anymore.
So I remember when I was in EMT, I was told I wasn't allowed to use a pulse ox. I think that's one of the other things, is a pulse ox is a tool just like anything else, and to reduce the amount of oxygen we give patients, put them on a pulse ox. If they're less than 90, if they're less than 95, then yeah, go ahead, put them on oxygen. If not, they don't need it.
Well,
can be
part of the
titrated
reason,
oxygen.
right?
Exactly.
And that's, I think, what they were showing a little bit here is that even if they truly did need oxygen, presumably because they had some underlying disease. I mean, these were cardiac arrest patients after all. They had something wrong with them. They just 4 liters was enough, and
Yeah.
that's often.
I'll go
all it
pick
takes.
up patients in like critical care units where they say, oh, they need 25 liters of oxygen, and I'm just like, okay, and I go there, and as I'm getting the report, I just keep on turning it down, and I keep on turning it down, and it's usually they end up, if they actually do need it, they need 4 or 3 or 6, not 25, because 25 liters.
they may need more if
So-
you take them up in the air or something.
Yeah,
right?
and that's the same thing. I'll dial it up if while we're flying, But I look at the pulse ox and I titrate it to what the patient needs, not just pumping it in there.
Part of the reason I think a lot of EMTs were taught that they can't use a pulse ox too is because the second they learn that it actually takes a pulse too, they stop actually taking pulses. So that's why it's avoided a lot of EMT training.
I've heard people say that. Say, it's a shame we can't have pulse oxes. I'm like, of course you can have pulse oxes. You're BLS. You can go buy them tomorrow. Well, I don't think we're allowed to do that. It's just another myth, right? Of course you can.
No, it's perfectly fine to use them. The problem is when they use them and then see someone who's got like nail polish on and then their stat is 80 and they're talking to comfortably,
Right.
that they upgrade everything. Or they put a pulse ox on, like, well, the pulse ox says the heart rate's 160.
It's still a
For some
device that
reason,
can
they-
react inappropriate to, especially if the device lets you use like waveform technology. I always say if you don't see a good waveform, ignore the pulse ox, right? I mean, the pulse ox is going to be bad when the blood pressure is 60, right? You're not going to perfuse the finger very well, so your blood pressure, your pulse ox is not going to read well. And when your cuff inflates, your pulse ox will go down because it won't read very well, right? It's just
I mean, it makes perfect sense. We
We always
just,
have a problem with crutches. I had a patient yesterday in the nursing home that, as we walked in, we were informed that the patient was in cardiac arrest, went through 8 rounds of CPR. The patient is now alert oriented. I came into the room and I found an AED on the patient, hooked up completely wrong, saying continue CPR as I was talking to the patient. So
yeah.
I feel bad.
thankfully, it wasn't a semi-automatic.
I feel bad for the patient who had to go through 8 rounds of CPR for no good reason.
Right. I mean, the answer is always the same. When something
chest pain. Right.
when something changes.
Bone pain in your chest.
All right. I say when something changes an electrical device or clinically, the first thing you do is you turn to the patient and say, how are you feeling? It's always the same thing. The pulse ox goes from 100 to 60, how are you feeling? Right? It's always the same thing. How are you feeling? And if they're feeling good and they're responding well and maintaining their brain, then you say, what information am I getting wrong here? Right?
That's from a medic perspective. These are nurses in a nursing home that are looking solely at an AED, telling them that there's no shock abort if continued CPR, and doing CPR without actually examining this patient.
Well, the machine wouldn't lie to them.
And breathing shallow, and had no question. You couldn't get a radial pulse on her because her blood pressure was 78 over.
Right. And you couldn't get a pulse ox because your blood pressure is 70.
Right. So they got no pulse ox.
And they was taking the blood pressure.
So they're sitting there doing CPR on this poor lady, and this is what goes on out there because they're totally relying on this machine.
It's too bad they didn't actually ask them to stop.
And then I couldn't get through to medical control because we didn't answer the phone all day yesterday. Josh was on an airplane somewhere. He was supposed to be answering the phone.
All right, you have 7,000 people listening. So, all right, any other clinical comments about the article?
I think we're seeing more and more of this. They reference a couple other studies, Finnish study where everyone who's intubated goes straight to an FiO2 of 30%, and they had all basically good outcomes, and others.
Yeah, I admit
There's a
my
bunch.
60% is wrong. I'm just, but I
I feel
started
the
out
same
as
uneasiness.
100, now I'm going to 60,
Right.
and I'm going to keep titrating down just as my baseline after I put them on a vent.
I-
I do know that's too high.
Well, I start low because if it's low and their pulse ox is low, because of that, someone's going to tell me, and we're going to go up.
Yeah, I mean,
If it's high, no one's going to ever tell me that, oh, it's been 100% for the last 5 hours.
There's several great papers written about putting these people on room air like right away after you intubate them and just seeing what kind of oxygen demand they have. Right, and I'm personally, I know I'm behind the times for this. I'm getting there.
It's hard. It's a hard habit to break.
I typically go to 30% while I'm standing there at post this event and while I'm getting more information.
So
And
what
then
do
when
you
I
do with
walk out of the
BLS?
room, I put it to 60% because I don't want it to fall down and then fall. And right.
What do you do with BLS? Now they have a BVM reservoir bag. They're bagging, their goal, their silly goal is to try and get to 100%, which we're not going to get to. What do you tell them now? To keep their bag deflated? Or do you tell them, don't put any oxygen on this person who's post-ROSC?
Get a pulse ox.
Yeah,
Yeah,
I think if you have a pulse
I'd say
ox-
look at the pulse ox, and by the way, the one I have in my bag is from Amazon and $10, and it has a waveform and it even has a perfusion index,
Right.
and you can tell if it's real or not real.
So are you saying
without
that we should
any-
create an EMS protocol where you don't give any oxygen post-ROSC if their SAT's above 93?
Why not
Yeah.
never give oxygen
Yes.
to anyone?
Yeah,
if their stats are above?
yeah. Nobody needs oxygen if your
93.
SAT's above 93. That's a bold
Car-
statement.
Carbon monoxide.
All right, so carbon monoxide, except for carbon monoxide.
Is 93 the number? Is that the number we want to go with?
Yeah, so I mean, I would generally go with 93. I think some of the things that you see that Weingart, right, sometimes he writes 90%, 93%. I think the problem in real life is 93 is an okay number, but our oxyhemoglobin saturation curve shifts to the left and to the right based upon all our patients' medical conditions, so we don't really know what their PaO2 is. So 93 is a nice guess. That's why sometimes I say 93, that's why sometimes I say 90%.
And that's why
at
you have that-
93, you know, it's when the it's when the PO2 falls off at, you know, it's the oxygen saturation curve. So at 93%, it's below 60, right? And 60 is generally for the patient who's less than 100 is outside the normal range.
That guy.
That protocol's written, it's never been enacted, but we have one written very similar to that.
So should we enact this? Oh, there we go. There's the old.
I mean, I think the
Should have a little more of an S though. I think, but,
Yeah.
The thought was for so long, like, okay, so maybe the oxygen doesn't help
Wiki
these people,
comments.
but it doesn't hurt them. But now we're finding
Now
out,
we're
well,
finding it's
you're actually, it probably is hurting them. Even in these,
So this is the problem, right? We don't know our patients' pHs. I think it's 2,3 DPG. We don't know what that is, and we don't know what their temperature is. And so this is why 93 is a guess, and that's why 60 goes up to 93% roughly, but the curve shifts.
So we should get, stat checks for a 2-3 DPG on every patient to, as
Is
hypothesis.
that
I
less
mean-
than Verboa? Verboa's
I mean, we just put a swan line in and then just do arterial sampling. Then
don't go backwards. So Bob, you want to do this? You want to create a? You want to do a protocol?
Like I said, I have the policy basically written that way, that anybody that, I think it actually says above 94%. I mean, we could change it to 93, that, the patient does not require oxygen, and it should not be put on.
I think it's a great idea. I mean, I think it's good to go back and look at these things that we've been doing for no good reason, or maybe at the time we thought there was a good reason for it, but just to stay with things for, 10, 20, 30, 50 years because we once did it, if we know that it's probably not the best thing for the patient. I mean, we've been living hundreds and hundreds of years on 21% oxygen, and our bodies, the less things we put in our bodies, the better off we may be in some regards. And if our body needs extra help, then we do it. But if it doesn't, why supersaturate people?
Does that 93% go down for a COPD patient, or do we keep that steady for?
I think if you have a COPD patient and you ask them what's your baseline oxygenation, and most of these people
they're
know.
not going to know.
And some people will know. I mean, or if they're not on oxygen normally. I mean, if they're not on oxygen normally, we know that they're not going to be below 90% normally.
Yeah.
It is
On
true.
average.
We get ABGs on these people,
So-
and their PO2s are like 300-400.
So,
And
I
they
mean-
haven't been that good in 20 years.
Right. So, I mean, I guess with the COPD patients, if they're on home oxygen, ask them what they're on and put them on that, see what they're setting at. If they're around 90%, then I say leave it. If they're setting in the 60s, then obviously, or they're looking blue, then put on oxygen. But I think we got to use our clinical judgment on these people and kind of see what's going on. But in the absence of lung disease and carbon monoxide, you know, does anyone really need oxygen below 90?
And there's nothing wrong if you don't know to titrate them up to 93 until you find out. So, all right, so let's do it. So what are we going to tell people who are intubated? We're just going to say use a BVM with no oxygen and see what the pulse ox is?
That's what I was just asking. How are the nurses going to react when we start bringing patients in with a pediatric bag and no attached to room air?
What's the difference if somebody's breathing room air to being ventilated with room air?
I mean, how do the nurses react when you put people on hypofronasal cannula and they think it's weird? And eventually they yell at you for not putting them on.
Yeah, well,
I mean,
Same thing with-
it's true. I mean, we're going to get yelled at one way or the other. I just want
Yeah.
to
I think for the intubated patient,
because it's great.
I think for the intubated patient, it's a little bit harder to just make a protocol. You know, I think if you have good waveform and you're really able to monitor the person and you can see that their oxygen is 100%, then fine. But what about these people that you don't know why they're in respiratory distress exactly? You know, and you didn't have a chance to take a sat beforehand. You know,
I mean, I think we
some
have
people are
to choose our battles.
Yeah, absolutely. I mean, I would keep the intubated person on oxygen for longer than I would the average person that would put oxygen on.
Right. But now,
But it also
It's not-
depends why you intubated them.
Right, absolutely. Right.
Define oxygen. Are you putting them on an oxygen reservoir on a BVM when you do that? Or are you just putting?
If they're intubated, you're saying? No, I mean, you got to breathe for them if they're paralyzed. So.
Right, but you could have an oxygen reservoir on the back of that BVM that you're breathing even 100%
Oh,
oxygen.
right.
Yeah, that's what I was thinking.
I mean, if I was there and I hooked them up to the monitor and I could see what they're saturating at, I would just titrate it to that.
how do you titrate it? I mean, they're just it's just an oxygen reservoir bag. You can't titrate it.
Oh, right. I guess that's true. You're either giving them oxygen or you're not giving them oxygen.
Right.
Basically.
So why not give
So
them?
I mean, you could try it. I mean, if they weren't hypoxic before I intubated them, if they're hypoxic before I intubated them, I would use oxygen after I intubated them. If they weren't hypoxic before I intubated them and they were intubated for a different reason,
All right.
then I would maybe not use oxygen.
So the
and
rule
see.
is cardiac arrest post ROSC. If the set's at least 93, they don't need the oxygen reservoir bag.
With a good
If it's-
waveform.
if it's less than 93, you give them the oxygen, and then when they get to the hospital, they can titrate it. Of course, the problem is instinctually, the first mistake everybody makes is when the sat starts going down, they start bagging faster. Right. So we don't want that to happen too.
I would also I would give the first couple of breaths with oxygen after intubation, and then maybe turn off the oxygen.
And Anthony Cassio, yes, had a valid point. Just remember the pulse ox lag, after you intubate somebody. So
Right. So we can. I'm a believer. It's a little bit more than people publish. That it's probably 8 squeezes in the bag, not less.
Are you
But
saying like 30
now with
seconds or 60
pre-oxygenation
seconds?
and apneic oxygenation during intubation, I don't
Oh,
see as
right.
much pulse ox lag at all. Significantly less than when we weren't doing that.
Right.
when I
That
was
is
medical
true.
student,
I agree
so-
with that, but I still do see it every now and then. Right. I still can actually remember cases where I saw it where I just go, just relax. Things are going our way here. Just
Yeah.
relax. I mean, your theory sounds good. You're making it up, but it,
No, yeah.
it sounds.
It's how you deliver it.
Right.
So, so Anthony, let's do it together.
There's a little bit of a delay with the stream today, but they'll get it eventually, so you can ask it in.
All right. So if we do it and Anthony does it, that's, I don't know, 3/4 for ALS for New Jersey.
I mean, I think I usually, if I have wall oxygen, I'll use wall oxygen and I'll deliver the first couple BVMs with that. But if I'm in the back of an ambulance and the patient has a good pulse ox, I'm not going to go through the trouble of getting a portable tank, hooking that up and turning it all the way up just to bag the patient when they're already sat and completely fine.
I mean, your argument is that give them a little oxygen for a couple of squeezes of BVM and then titrate it off. I mean, it's just another thing for ALS to do on the scene of a cardiac arrest. Why not just don't give any if the guy doesn't need it. And I mean, does a few seconds of oxygen do anything for free radicals to change outcome? Probably not, but I don't know.
Yeah. I guess if you're
It's one more
pre-oxygenating the
thing to deal
person and you have the nasal cannula on, you probably don't need to connect the BPM to oxygen.
Yeah, I mean, you're pre-oxygenating
Right,
a little bit.
you're
You're
pre-oxygenating
denitrogenating. That's why you're
Yeah.
pre-oxygenating,
Right.
right? So you're doing it for a different reason.
Yeah.
Now you're not denitrogenating them so much, or you don't need to so much. You get maybe getting those people back to a baseline nitrogen load in their lungs is the best outcome.
And hopefully, if you intubate it right, the nasal oxygen isn't going down the lungs anymore.
All right, so let's do it. Probably want to do it. Well, we have the
Policy change.
But
That's how it happens, folks.
So for the post-ROS patient, I mean, we're just going to say no oxygen unless you're 93. And we have new pulse oxes, right?
We can.
All right.
All right, good.
I think on the BLS level, I mean, you want to talk about money savings. How much oxygen do we go through on the BLS level? I don't know how much oxygen. How much oxygen costs? Like, if we stop giving oxygen to all these people who have arm sprains, you know, how much money would we be saving there as well?
I mean, do any of you guys know how much oxygen, a tank of oxygen costs? Josh, do you know?
It depends on bulk, really, because a lot of people use cascade systems. I think we buy them directly, so we can check with our guys.
Right. I mean, I assume an M10 is
But
more
even just like the non-rebreather at $10 or $8 each,
Yeah,
right?
just for the plastic.
Not that
yeah.
much, I'm sure. I mean, it must be
Do
similar.
you know how much a non-rebreather is? I mean, I do know that the nasal cannula and title is like $8. Right. So,
What we do, my partner and I, as a rule of thumb, because generally when you're in an ALS situation, you're not doing the bagging. BLS guys are doing it for you. We have too many other things to do than we have ALS providers. My partner turns the monitor to the BLS provider doing the bagging and says, here, watch this waveform, the ETCO2 waveform. And we want to keep it between 35 and 45. And if it goes above 45, we want you to slow your bagging down. You keep it at that level. So keep your bagging at eight times per minute, and if you watch that number change, that's going to modify your bagging. That works every time.
right. No, I think that's brilliant.
Because it gives them something to do.
And it
too.
works, right? When they do that, right? I think that's brilliant. It's just like when people say, you know, do you want me to hyperventilate this head trauma patient who's herniating? I always look at them and go, well, what do you mean by hyperventilation? The American College of Neurosurgery definition is a PCT less than 35. Is that what you're asking me? You know, and how fast or slow you should bag depends upon, you know, is a made up thing. I'll pick an end-tidal CO2, and that's how you fast or slow you should bag to keep that number.
Right, that's what we do.
Yeah, that's great.
This needs to work every time, because the SpO2 monitor, the pulse ox is a latent indicator anyway. And half the time it doesn't work, and every time they're moving, it changes. And if you have a blood pressure cuff on the same arm, then that gets messed up every time you get the blood pressure. So, and the guy doing the bagging is not watching the SpO2 monitor.
And I bet BLS is coming back to you saying, you know, we're bagging much slower
Right.
than we used to bag.
Exactly.
Right? And they're surprised.
When we teach that with BLS providers, especially like at PHTLS when we're doing it, they can't, they're like, this is wrong. You know? Well, we've never bagged that slow before.
Right.
It's like just because you have it doesn't mean it's not right.
Right. It's statistics. It's not that you're doing such a good job now, it's that you were doing a terrible job before. All right, AJ, what are your thoughts?
Well, a lot of the study has to do with clinical significance and the association between that because, I mean, the sample size is pretty low. There is some confounding with the age variable and the fact that most everyone's male. So it doesn't really infer upon most population groups extremely well. So that can be a big issue with determining the best association of this effect size with 94% and 90%. For the sake of time, if you have any questions, I'll try to answer those.
Questions, anybody? No?
Yeah, there are no tables or anything.
All right, I know we only have like 5 minutes left. Was there one article that you guys want to do quick? Anything that's a shorter article?
Not sure.
Not short, I know, not short.
I mean, we can
mean,
move
you
these to next week.
All right, I'll move these to next week, and then
Then we can let Alex talk about the fixed
Yeah.
point temperature one, you know.
Yeah, one of our doctors actually took vacation. It must have been a mistake in the schedule. But I'm sure he's online, right, watching us?
Yeah, if
We'll
he
move these
is,
articles to
then
next
can't
week,
see him, but-
and we will put a few more up. I'm going to start doing this. I'm going to start putting a few extra articles every week and just let all the docs pick which articles they want to review, just so everybody has more articles in their repertoire. And don't forget, freaking one more time, to sign up for EMS conference, May 22nd, 4 p.m. to 10 p.m. Bring 10 to 20 friends. We have
We'll all be there.
we'll all be. We have 20 speakers, a great dinner, lots of people coming from different walks of life to be honored, or we're getting plaques for, et cetera, et cetera. So make sure you are there. Make sure everybody make sure your partner who sits on the bench next to you with a sick patient is there. If you can read in a book, we're not gonna talk about it at EMS conference. All right. Anything else?
Oh, also just make sure you register, because we have to order food. So it would be good if we had enough, and not too much and not too little.
And we are going to be here in the boardroom, if anybody's curious, we're going to be here in the boardroom at Monarch for the next 2-3 months, because we are in interview season for fellowship now. And so we're going to be in South Jersey for a couple of months straight now. Okay? Thanks for tuning in. We will see you next week.
Okay, and we